So, Dr. Scholz, today we're talking about high-risk prostate cancer and in regards to our staging system that's actually high Azure, and talking about unfavorable high-risk prostate cancer. And Azure is part, as you know, our 5 stages of blue. And so really we're going to be covering different treatment options and really unorthodox treatment options when it comes to this category. So our first question is there a benefit to adding a second-generation anti-androgen or chemotherapy to standard hormone therapy to treat unfavorable high Azure for prostate cancer?
I think the simple answer is probably yes. The high Azures are the ones where we're struggling a little bit more to try and cure them, and every resource that can improve cure rates is desirable. And if you look at the second-generation hormones like Xtandi or Leda, Nubeqa and Zytiga, the side effects really aren't that much worse than Lupron. So there is a clinical trial called STAMPEDE that has looked at outcomes in these people, and it does show better cure rates when you add one of these second-generation hormonal agents to the standard Lupron that's always used when you treat high Azure.
So what about adding both? And is there any situation where you would add both automatically?
Well, unfortunately, we don't have any clinical trials to see if adding chemotherapy like Taxotere to a second-generation hormonal agent will translate into enough survival advantage or enough higher cure rates to justify the side effects of the chemotherapy. But it's logical to guess that maybe adding chemotherapy to these second-generation hormonal agents might add survival. It works by a different mechanism, and of course, independently, they have been shown to add survival. So the kind of people that you want to have a discussion about doing both a second-generation hormonal agent plus Taxotere are those men that are younger, have more years of life at risk, and those that have particularly high risk from the cancer, very high PSAs, cancer spread into the lymph nodes of the pelvis, seminal vesicle invasion. These all equate to lower cure rates with standard treatment.
So in the case that you would only give one or another, would the second-generation hormone therapy like Zytiga or Xtandi, those are the trade names, or chemo be more beneficial in some cases, or would they have less side effects?
So if you're trying to pick between either doing chemotherapy alone or a second-generation hormonal agent alone, I don't mean alone, everyone gets Lupron, everyone gets radiation, but the side effects of the second-generation hormonal agents are generally perceived to be quite a bit less than Taxotere. People are guessing, there's never been a head-to-head trial, but they're assuming that the improvement in cure rates by adding a second-generation agent or Taxotere will be about the same benefit. So naturally, you're going to go with the less toxic one. And I would say the vast majority of men in this situation are being treated with Zytiga, Xtandi, Erleda, Nubeqa type agents. It's becoming more and more routine.
How well do patients usually tolerate the first generation, so Lupron plus chemotherapy, when they're getting these treatments?
Pretty well. A lot of the protocols involve 6 Taxotere treatments, which are administered intravenously every 3 weeks. And sometimes we'll cut that back to 4 treatments. We think the lion's share of the advantage is in the first 4 cycles, and a lot of the toxicities in the last 2 cycles. So talking about over a 12-week period, getting 4 treatments, a little bit of hair loss, some fatigue, inconvenience of going to doctors and getting blood tests and whatnot. So it's not too bad, really, but can't compare with just taking a pill like Zytiga or Xtandi.
What would you say distinguishes a high-risk patient who would benefit from upfront chemotherapy or a second-generation anti-androgen versus a high-risk patient who would not benefit upfront?
Well, there's quite a broad spectrum in high risk. So people can be high risk with just, if they have a random biopsy, a single core shows Gleason 4+4, that's a favorable type of high risk, and assuming that the PSA is less than 10 and that no one can feel any large lumps on their digital rectal exam. So if we're talking about unfavorable high risk, we're talking about people with PSAs of 30 or 40 or lymph node spread, and I'd say that if you just talk about unfavorable high risk, you're talking about almost all those people are going to benefit by a more aggressive stance. Until they get up into their late 70s, maybe, and then you don't pile on with so much treatment.
Thanks so much for watching. If you would like more information on any copay programs or financial assistance when it comes to these second-generation hormone therapies, you can visit our website at PCRI.org and also contact our helpline. There's many programs out there that can help you pay for these somewhat expensive drugs. Also, if you would like more information on anything that we discussed today, you can visit our website at PCRI.org and also subscribe to our YouTube channel. We come out with new prostate cancer videos every week.